So, Dr. Hassan, Dr. Khalid, Dr. Osama, it's a pleasure. After Abdu's lecture, of course, I have little to say. He covered most of the things about lead extraction. I have another additive point about the tools which we can use about lead extraction. At first, I will go through whether we need lead extraction or not. Actually, this is an actual patient. He's 80 years old. He's post-CABG. He had a pacemaker implanted from the left side, and this was before the CABG. It was something like 12 years ago. And then later on, he had malfunction of both leads with an infection and erosion of the battery. So he went to a center where they extracted only the battery, leaving the leads inside. And implanted another ICD from the other side, from the right side of the patient. And then the patient presented 1 year later with erosion of the leads from both sides. So what do you think about this patient? What do you think should be done? Actually, as all the guidelines stated, as Abdu said, every hardware should be removed when we suspect infection in these patients. It's not enough to remove the battery and leave the leads inside, because at a time or another it will erode and you will be in a big problem. You have to extract all the leads, and the older they stay, the more difficult they will be to be extracted. And from the increasing need of, this is a very old lead, of course, which is the Acuflex that Abdu showed. It's a J-shaped atrial lead, which showed inside-outside insulation break with protrusion of the insulation part, which is J-shaped, that can puncture the right atrial wall, causing tamponade. And this is actually a lead performance chart through the Kaplan-Meier. It shows that the RV leads, whatever the type of the lead, at 10 years it has more than 20% instance of failure, regardless the type of the lead, regardless the company that produced the lead. Actually, there is a little bit difference between the different companies, of course, and as the lead French increase, the rate of failure increased. So with the older leads, which was 11 French, like the defibrillator leads, it carries more risk of failure than the newer ones. Yet there are some specific leads which shows failure, like Abdu stated, the Medtronic Reata lead, of course, Medtronic Sprint Fidelis, sorry, and the St. Jude Reata leads. It shows inside-outside insulation break, and they should be removed in these patients. And this is a registry from the European Society of Cardiology that shows the rate of extraction, the rate of failure, and the rate of complication. And the extraction, of course, is a tedious process. It carries some serious risk for the patients, so it should be done once indicated only. So what's the indication of lead extraction? The first and the most common and the most solid is the infection or the sepsis. So any patient present with an infection that extends beyond the superficial skin layer should have a complete removal of the hardware. So infection is the most common cause of lead extraction. And then the damaged leads. Not every damaged lead should be removed, but the damaged leads that can cause arrhythmias and can cause venous trauma, like the Acuflex lead that we showed. Secondly, unable to implant additional leads due to occlusion of the vein, and you have no other alternative. So when the patient has something like 2 or 3 leads, like a CRT patient, and then you inject and you find the vein at the same side is occluded, you should extract one of the non-functioning lead and implant through the same track another additive leads. Another indication is the thromboembolic events. When we leave some retained leads, as there are some papers that the leads in the RVOT, when retained and non-functioning, it can cause some thromboembolic pulmonary embolism in these patients. Another indication that lead that interfere with the operation of another implanted lead, like when you implant an ICD lead very near to an old abandoned lead, it might interfere and produce some interference on the newly implanted lead. So at this time it should be explanted. The infection reported in 4 to 7% of the implants. Erosion occur when the generator and or the leads exit through the skin. Staph epidermidis is the most common microbe, while Staph aureus is the most virulent, of course. It can be located in the pacemaker pocket and also along the lead biofilm, and can lead to infective endocarditis. To eradicate an infection, it's universally recognized that you must first remove all the hardware. The damaged lead can be caused either by trauma to the lead, which is one of the common causes when the patient presented with a trauma to the pocket and the leads, or during implantation of another lead, or a reaction of the hostile body with extensive fibrosis to the lead. And one of the most common causes of the damaged lead is the faulty implantation. It is very, very, very common that we implant the lead very close to the clavicle or through the claviculo-chondral junction, or the fibrous tissue that's present between the clavicle and the first rib. And it can be recognized during implantation by the resistance while we introduce the peel away, and it will lead later on to lead fracture at this point, which is called subclavian crush syndrome, of course. Or it can be damaged during the extraction of another lead. So as we can see from this X-ray, we have an extensive lead fracture under the clavicle, which is a part of the subclavian crush syndrome. And this is the acuflex lead that Abdu mentioned, which has insulation, inside-outside insulation break with the exclusion of the very sharp part of the insulation that can puncture the right atrial wall, of course. So what's the problem with the damaged leads? The first, arrhythmia due to broken lead striking the epicardial wall, muscle stimulation, endothelial wall damage, and potential puncture of the heart wall and large vessel like the J-wire design we showed before. Unable to implant additional lead is one important indication of lead extraction. If we have too much implanted hardware, like Abdu said, if we have 4 leads from one side or 5 leads in the superior vena cava. I had a patient with a dual chamber implanted pacemaker, and then this patient presented with erosion of the pocket 16 years after implantation because he had a battery exchange 3 years earlier. So I had to extract a 16-year-old passive fixation right ventricular lead. Although it came out, yet when I implanted another pacemaker from the other side with a dual chamber pacemaker, the patient came later with a superior vena cava obstruction, superior vena cava obstruction syndrome. Although we don't have any leads inside except the 2 leads, but yet the 2 previous leads, they did an extensive fibrosis in the superior vena cava, leading to much narrowing, and that this patient had to undergo a balloon dilatation of the superior vena cava in order to overcome the superior vena cava syndrome, of course. And this is the example of large vein occlusion. So re-implanting through the same tract as that of the removed lead is the key. So what's the big deal in extraction? You can just pull it like a man with extensive force, but this may lead to avulsion of the myocardium, because after a while the chronic lead has a binding scar tissue, which is that myocardial reaction to the external elements or the elements from outside the body. It can cause extensive fibrosis, and this fibrosis can be through any point of contact between the lead and the body, including the subclavian part, in the subclavian vein, the junction between the subclavian vein and the superior vena cava at the innominate part, and the most dangerous at the superior vena cava itself, and then of course the adhesions inside the myocardium, inside the right atrium and the right ventricular wall. The scar tissue location as shown in this picture, it's almost 70% at the subclavian at the entry point, and we have 36% at the superior vena cava, and 71% if you implanted this at the apex of the heart. The chronic lead also has a very poor lead design that can be damaged during explantation and leaving parts of the lead inside, and we have a very fragile material as well. The implantation technique the entry location can be a headache during extraction, so we always recommend when you implant a pacemaker on ICD, always think about the extraction of these leads. You have to implant it without a resistance while introduction of the peel away in the subclavian vein. This is number 1, and you should try to put it in the septal position in the right ventricle, because the septal positions, although it's similar in the synchronization and similar in the outputs and similar in the failure rates in terms of dislodgement, but it is much easier in extraction and with less complication, because the apex is very thin part. You can lead to perforation during extraction, and the patient anatomy and physiology is different. Everyone is different. So one patient, you have an extensive fibrosis throughout the lead, and what the other patient during extraction, when you expect extensive fibrosis, it comes easily with just a locking stylet inside. So the lead extraction tools, nowadays most of the leads are extracted through a minimally invasive approach or transvenous approach, either superiorly through the subclavian or the jugular vein, or femoral approach, which is the inferior approach through the femoral vein, of course. So the superior approach we need this preparation for each patient for extraction. We need a surgical team on standby or even inside the operating theater that should be done in a hybrid room. This is the best setup. Pericardiocentesis set, typed and cross blood, transesophageal echo when possible, high quality fluoroscopy, thoracotomy tray. And these are the categories of lead extraction. We should at first control the lead in order to avoid it to be fragile and damaged during the extraction. We need something like locking stylet and BULLDOG stylet. Vessel entry, we should go inside the vessel in order to make the extraction feasible. We can enter the vessel either with using the evolution, which is the mechanical extraction tool, or the bell dilator, stainless steel dilators. And then the extraction tools itself, which can be either mechanical or powered extraction tools, as I will show later. And then with the extraction from the femoral approach, we need, of course, the snares. So at first, we'll go through the lead control, how to control the lead to prevent its damage. The first step is to enter a locking stylet. Locking stylet is just a stylet that can be corrugated inside the lead to maintain its integrity as one point, and prevent it from being fragmented during extraction. So it's very simple. We can use the stylet as far as possible inside the lead, and then, as it's shown in the diagram below, we should pull the ring of the locking stylet in order to corrugate inside the vein, like inside the lead, like this, and so it maintains the lead as one segment and preventing it from its fragmentation, and gives the power through the whole lead in order to apply your power till the apex of the heart or till the site of implantation of the lead, rather than being the power just at the introduction point. So the locking stylet, it is very important to be as far as possible inside the lead, and to make sure that it is stable inside the lead. It will not come when you pull. So the locking stylet is the first step. But some leads are lumenless leads, and we have we don't have the possibility to enter a locking stylet inside. So they invented something called the lead extender, or the BULLDOG lead extender. It's similar to the locking stylet and can be used in order to extract the lumenless pacemaker leads, and to extend a broken lead or broken liberator or locking stylet as well. So once we maintain the integrity of the lead, we need to go inside the vessel. We go inside the vessel with either the stainless steel or the PTE dilators, which works mechanically by dilatation of the vein with different sizes until we get a clear access inside the vein, or using something called the evolution or the shorty mechanical extractor device. The shorty is a mechanically powered extraction tool that can clear the fibrous tissue around the leads to make a clear entrance inside the vein. So the evolution or the shorty, we should at first free the leads, open the pocket, remove the pacemaker, remove the generator, and then free the leads and make the shorty in a parallel axis to the leads in order to avoid injury to the vein wall. So it must be in a parallel fashion and not perpendicular, like the incorrect picture at the right side. And then after we go inside the vein, we should make more force to dilate and remove the fibrous tissue from around the leads along the whole course of the superior vena cava till the apex or till the implantation site of the lead. And for this we have either to do it manually with the manual mechanical telescopic dilator sheath set that have different sizes, of course, and we will go upgrade to the size until we make sure that we remove most of the fibrous tissue around the lead. And this works in most of the cases, actually. In most of the cases, we don't need more than these mechanical dilators in order to get the fibrous tissue away from the leads. And it works with a counter traction method. We just pull on the locking stylet, which we introduced inside, and then we'll do just pushing with the rotation of the mechanical dilator sheath in order to reach as far as possible inside the myocardium. And this is explaining the counter traction, as I said. It's just pulling on the locking stylet with pushing of the dilator sheath inside the heart in order to remove the fibrous tissue. It's called the counter traction process. And if this fails, we can use either the powered devices like the EDS or electrosurgical dissection sheath. It's powered, and it's powered with the radio frequency ablation of the fibrous adhesions around the lead. And of course, we have the laser powered sheath, but it's not available, of course, in the market in Egypt because it's very expensive and also it's very dangerous. And then we have the mechanically powered cheese, which is the evolution, of course. The evolution is available in Egypt, and as we can see from this registry, the complication, I don't have a marker in here. Let me use this one. Okay. As we can see, it's the complication with the laser extraction or the electrically powered tools for the extraction is much more than mechanically extracted tools. So we recommend that mechanical extraction has a lower adverse rate than the powered cheese. So as it is cheaper and available and with less complication rate, we adopt the mechanical extraction tools in Egypt rather than the laser or powered extraction tools. And so this is the evolution, as I mentioned. It's a longer form from the shorty, and the evolution can reach down to the implantation site inside the myocardium, inside the right ventricle. Okay, and then we are left with the snare. The snare is usually used from the superior approach in order to remove the 3 minutes, 2 minutes, 2 minutes, okay. So the needle eye snare, we can use it to remove the fragmented part of the leads. This is from the superior approach, or it can be used either entirely as the only extraction tool if we use the femoral approach in these patients. Okay. So if the superior approach fails, we have alternative approaches like pulling, weight traction, as it was the previous methods before, or thoracotomy and removal of the lead from thoracotomy, or we can use the femoral approach with the needle eye snare. I know Dr. Mu'taz is very fan of the snares. He's the snare guy in here. The beard workstation, it's like shown in this figure. We just try to grab the leads in the right atrium because it's rather the smaller chamber, and then we grab the lead with the snare, and then the snare will give us enough mechanical force in order to put it outside. The needle eye snare it's not a normal snare, it's a 3-dimensional snare that can grab the leads very well between the two hooks of the snare, and then it's put inside the inside the sheath of the snare and be pulled outside. This is the way it works. And finally, we have some factors to consider, as Abdu said, regarding the extraction. The patient age and gender. Elderly women have a higher risk, of course. The overall health of the patients and lifespan. Previous cardiac surgery. Number of leads in the intravascular space. Duration of the implant. Fragility, condition, and physical characteristics of the lead. Experience of the physician and desire of the patient, as we also compare risk versus risk. Risk for leaving the lead and get a future complication, and risk of extraction nowadays, and we get a complication on site. Thank you.